All right, today we are going to dive into a really fascinating medical mystery. It's all about two organs you might not think are directly connected, the kidneys and the lungs, and a puzzle that doctors have to solve when things go wrong. So, here's the central question we're tackling. You've got a patient, and they have kidney disease. So why on earth is fluid building up in their lungs? I mean, it seems a little strange, right? These organs are in totally different parts of the body. How can a problem way down here cause such a serious issue all the way up here? Well, that's the puzzle we're going to piece together. First things first, let's get our terms straight. The condition we're looking at is called a pleural effusion. Just think of it like this. It's unwanted fluid that's building up in that super delicate lining around the lungs, which, as you can imagine, makes it really hard to breathe.
Now, to solve this mystery, a doctor's first move is basically like a detective's. They have to analyze the evidence, and in this case, the single most important piece of evidence is the fluid that they've collected from the patient's chest.
And this, right here, is where the investigation really kicks off. The fluid itself immediately points us down one of two paths. Is it a transudate, a thin, watery fluid that suggests a problem with pressure, which you can kind of think of as a physics issue, or is it an exudate, a thick, protein-rich fluid that hints at inflammation, which is more of a biology issue? Answering this one question is the key that unlocks the whole puzzle. So let's start by following that first trail, the case of the thin, watery fluid. If the fluid is a transudate, we're on the hunt for problems related to plumbing and pressure.
Okay, so our first two suspects are all about pressure imbalances. With end-stage renal disease, or ESRD, the kidneys just can't get rid of enough fluid. This creates this high hydrostatic pressure. It's literally pushing water out of the blood vessels, kind of like an overfilled water balloon. Now, on the flip side, you've got nephrotic syndrome. Here, the kidneys are leaking out way too much protein. See, protein in your blood acts like a sponge, holding fluid inside the vessels. When that's gone, the oncotic pressure drops and fluid just leaks right out. So you're either pushing fluid out too hard or you're failing to pull it back in. Either way, the result is the same, a watery leak into the chest.
But what if the problem isn't some subtle pressure imbalance? What if the plumbing has a more direct mechanical failure? You know, sometimes there's an actual leak somewhere in the system, and the fluid is taking a very, very unexpected path. This brings us to a condition with a pretty wild name, urinothorax. It's a journey, step by step. First, you get a blockage in the urinary tract that causes a high-pressure leak. Then, that urine starts to pool behind the abdominal cavity. And from there, it can actually travel through tiny little holes in the diaphragm and end up right in the chest. And yes, you heard that right. That fluid around the lungs, it's literally urine.
So how do we prove it? Well, this is the smoking gun. If you check the ratio of creatinine, which is a waste product, in the pleural fluid compared to the blood, and that ratio is greater than 1, it is a dead giveaway. That fluid in the chest came from the urinary tract. Case closed.
But that's not the only kind of direct leak we can see. Something really similar can happen with patients who are on peritoneal dialysis. In this case, that special dialysis fluid they use in the abdomen, it's called dialysate, it gets forced through those same kinds of tiny holes in the diaphragm, leaking from the belly straight into the chest.
And just like with the urinothorax, there's a definitive clue. That dialysate fluid is packed with glucose or sugar to help pull waste products out of the blood. So finding a crazy high level of glucose in the pleural fluid, it's another smoking gun. It points the finger directly at a peritoneal dialysis leak. In fact, clinicians even have a nickname for it, a sweet hydrothorax. Okay, let's totally switch gears. What if the fluid wasn't thin and watery, but thick and full of protein? Now we're following the exudate trail, and this path leads us to problems of active inflammation and disease. Our first suspect here is uremic pleuritis. Now this isn't a pressure problem, it's a chemical one. When the kidneys fail, waste products called uremic toxins build up in the blood. These toxins can actually directly attack and inflame the pleural lining. This makes the capillaries super leaky, causing a protein-rich, often bloody, inflammatory fluid to just seep right out. So the clinical clues start to line up pretty quickly. A doctor might suspect uremic pleuritis when a patient isn't getting enough dialysis, or when that effusion just doesn't get any better even after their fluid levels are corrected. The patient might also complain of a sharp chest pain. This tells the doctor the problem isn't just water, it's inflammation. And well, logically, the treatment isn't just to drain the fluid, it's to treat the root cause, clean the blood better by intensifying the dialysis.
And finally, we come to our most serious suspect, a malignant effusion. Sometimes, a kidney cancer, like renal cell carcinoma, can spread or metastasize to the pleura. The tumor actually invades the lining, blocks up the drainage system, and causes a persistent, exudative, and often bloody effusion. Finding cancer cells in that fluid is what confirms this tough diagnosis.
So we've looked at pressure problems, direct leaks, inflammation, even cancer. How does a doctor put all of this together to actually solve the case? Well, it all comes down to a really clear, systematic approach.
And this slide, right here, basically lays out the entire diagnostic pathway. It all starts with that one key question. Is the fluid a transitate or an exudate, thin or thick? That single answer narrows down the possibilities immensely. From there, you just hunt for the specific markers, those smoking guns we talked about. Is the glucose sky high? It's a PD leak. Is that creatinine ratio off the charts? It's a urinothorax. Is the fluid bloody and inflammatory? Then you start thinking about uremic pleuritis or even malignancy. It's just a really powerful and logical process of elimination.
And that brings us to our final and I think really powerful takeaway. A pleural effusion in a patient with kidney disease is never just some fluid in the chest. It's a message. It's a sign that something is wrong with the whole system. As the quote says, the pleura acts as a sensitive barometer of renal dysfunction. It's just a perfect reminder of how deeply interconnected the human body truly is. Thanks for joining me on this explainer.